We're going to turn things over to Cyndee Clay from DC. And Cyndee, I think you have muted yourself, so it's not, I didn't do it this time. Cyndee, whenever you are ready, you can go right ahead. Cyndee, are you there? I'm sure Cyndee is panicking right now, so Cyndee, don't panic. Well, why don't we just take a minute and do a brief discussion while we wait for Cyndee to reconnect. Daniel, anything that struck you about Elisa's presentation that you would like to comment on?
Well, yeah, I get inspired every time I hear Elisa talk about this stuff, and I think that what Washington State is going through is very familiar, and I've been out there and talked to people in the programs in the health department there, that this inverse relationship where, because HIV rates amongst people who inject drugs as a proportion of new diagnoses or new infections are declining, following the national AIDS strategy of the money should follow the epidemic, there's a risk of disinvestment from traditional funding sources for syringe exchange and harm reduction. And I think that this kind of creates a crisis, again, but also an opportunity for us to all step outside of our comfort zone and figure out who else should be paying for what we're providing. And it looks like Cyndee's on.
Yes, Cyndee is back. Thank you, Daniel, for that comment. Cyndee, why don't you go ahead?
Hi, everybody, and I have no idea what happened there. But I'm glad to be on. If I could just go to the next slide, please. So HIPS has been working on responding not only to healthcare reform, but when the National HIV and AIDS Strategy was beginning to come out, or when we were developing it, as well as the concept of high-impact prevention. And for those of you in the HIV prevention world, the death of the Debbies or the Ebbies, or the slow demise, I guess. You know, we realized that there were a lot of things that were happening that was really making that was going to make some big challenges for us in the future. And where we are slightly different is, while HIPS serves drug users, for the first probably 15 years of our lives, we primarily serve non-injection drug users. So we've only been running a needle exchange since about 2007. And so we probably, we also have worked extensively in the domestic violence, victim services. We've worked in other worlds other than just HIV. We had never actually worked directly with care. We've always been a prevention organization, primarily because all of our services were anonymous, and we didn't want to tie anyone's HIV status to engagement in sex work, because that can be criminalized, you know, or some other issues with the agency. And so we realized the need to address this. And so there was this concept of the sky is falling, funding is drying up everywhere. The rise of the trafficking movement means that harm reduction-based sex worker organizations are having a harder and harder time finding funding for the services that we do. So we realized that we needed to make a change. Next slide, please. So that's what I just talked about. There are also some local changes and opportunities that we needed to address, such as the local funding, the local ban on DC using its own funding for syringe exchange, and the district government deciding to roll out syringe exchange happened. So these are all opportunities that we realized we really needed to address. Next slide. So what we did was we decided that we really needed to take a look at who we were and what we did. We needed to look at the threats and the opportunities. I mean, we all do SWOT assessments, but really to kind of look at what is impacting our ability to be effective and what's going to impact our ability to make a difference in the lives of the people that we serve. And so we started by doing a very honest inward look at what we do best, what we don't do necessarily well, and how many of those things directly relate to needs that our clients have, and not just needs around HIV prevention, but if we wanted to have like a real change in the health and the lives of drug users and sex workers, which are our primary target populations, what would that look like? And what do we need, or what does DC need, and then actually bringing it above our own issues in order to reach that? And there was a parallel response in the sense that, you know, all of this stuff is happening, but we're going to, very much like the plane analogy that Alyssa used, we're trying to change, move forward, change, move forward, change, move forward, and we're working on very many levels at once. So this sounds a little bit terrifying if you haven't done this, but for us, while it was a challenging thing to go through, I think we emerged much stronger, and we have a better sense of self. Next slide. So one of the things that we did was we did actually work with the Harm Reduction Coalition, who came down and provided us some technical support on doing some focus groups. And we talked about who of our different, community stakeholders are and how we can talk to them about the value that they see HIPS having in the community. And this is the thing that Daniel and Alyssa were talking about as far as, what is the value of HIPS, and what would it be like in DC if HIPS hadn't been providing services for the last 20 years? And then how do we leverage that to do what we do better, tell better stories, improve our data? And that just meant talking to a whole range of people. And this is an example of what people kind of said, the main words that were used when they talked about us. And this helped us think about not only what we did, but how we were perceived, and how that needed to maybe change, shift, or how we need to leverage that. Next slide, please. So again, we sat down and we said, what do we want, not what can we have? And so we did a lot of perfect world scenarios. One of the things that we were most excited about was looking at this concept of time billing, and what Daniel was talking about is this fee for service, is this, how are we going to get ready to direct bill? Can we even do that? We had never really had any of these types of conversations before. We sat down and we did a time study with our staff, and we said, okay, so we have, if we talk about specifically around HIV, if we have an HIV positive client, whether they're engaged in sex work or whether they're engaged in drug use, what does this person's life look like? How do they interact with HIPS programs? And then what would it take if we looked at the end goal of them having a healthy relationship with a medical home model, which is what DC is working towards, and a self-sustainable life? What resources do there need to be to get that person there, and then what resources do we need to have as an agency in order to support that person getting there? And we basically put like our perfect intervention together. It relies heavily on community health workers, which in many cases are our peer educators, are our secondary exchangers, are people in the community that we have been working with for a long time. It's just redefining a little bit what they do. And also relied on just asking, like, is it transportation money? Regardless of what the funding will or won't give us, what do we want? And we use that to develop a cost actually per client as to what it would take to get somebody from initial HIV test or hepatitis C test, because we're also doing hep C testing now, into, all the way through to, not only making their appointments, but viral suppression and or reaching a public health goal. And we talked about integrated services. So at this same time, we integrated hepatitis C services, so testing, counseling. We tried to integrate access to treatment. The problem is that treatment just is not accessible for the vast majority of our clients at this point. Hopefully that will change soon. But we did kind of have some stumbling blocks as we tried to fit ourselves into a larger clinic base. And some of the things that Alyssa talked about as far as the clinics just not having time and being these large behemoth agencies that you can't get into to talk to about their services, were definitely issues that we faced and we're still facing. But really what we were trying to do is, as has been said before, is leveraging our specialties. And that is, community engagement. We have access. We see people on a regular basis because they're coming to us regularly for either syringes or condoms or other services. And the fact that we're quite frankly, harm reductions organizations are creative, and we're willing to do what it takes. And I think that can't be, brushed aside as something that's really important. Next slide, please. So we emerged from what was about a 2-year process with a new strategic plan, which is really, it's not this long document that doesn't really, that you put on a shelf and you don't think about, but it's really goals that we want to reach over the next 3 years. And then that helped us look at what kind of funding we need to go after, who we need to partner with, where our office needs to be, all of these things. That was designed from focus groups, surveys, and one-on-one communication with a vast majority of pretty much everybody who's involved with HIPS, in different ways. So volunteers, staff, clients, a lot of clients, in different types of clients we were only seeing on outreach versus clients that we were only seeing in the office, clients who only access us for condoms and syringes versus clients who are coming in for case management or drop-in center services, really kind of teasing out what our relationship with and what impact we were having in their lives. Next slide, please. And then we also participated in some regional discussions on responding to healthcare reform. We were lucky because of my involvement in a couple of just key community meetings and key community activities that we saw this coming 2 to 3 years ago. And so we started trying to address it. And I will, again, like you probably, I don't know about everyone in the room, but I constantly felt like I was crazy because I was like, I get it, I don't get it. I get it, I don't get it. Like it was a constantly moving target that I just felt like I could never, to out myself as a complete geek, like I just couldn't grab the snitch, to use a Harry Potter reference. Sorry. But I did have a moment at this one institute on potential collaborations between medical centers and how reform was going to change the game for Ryan White care providers. And I wasn't a care provider ever. I just decided to go to this meeting that was hosted by the Institute for Public Health Innovation. And I had this like skies opening, cloud clearing moment where I'm like, the clue here is like, it's health reform and it's important and it's really not important in the sense that what we, at least as a prevention organization, was being asked to do was change. And we've been being told for the past 3 years that we need to change. And in reality, they're trying to change us to fit into a system that has not yet changed, right? So they're asking us as prevention or as on-the-ground organizations to change what we're doing because we're now focusing more on care and how care is leveled out. Because linkage to care in DC is good. We don't have an access problem. 90% of people in DC have coverage. The problem is that we are bad at retaining people, and we have these other unnecessary health expenses, as Daniel was talking about, like hospital readmissions and people not remaining in care once they're linked. And so the whole point of it is that, well, we're not crazy. We just need to be better at leveraging what we do to help the care and medical organizations do what they do better. And once I understood that, and again, at least in our region, this is what I see as what's going on. It might be different in your regions, whereas people in other areas are talking about they just don't have enough providers, and I agree with them. But in DC, at least, this isn't an access problem. But it's a sensitivity and it's an expertise problem, and HIPS has a place at the table in helping people build that expertise, and so we need to leverage that. Next slide, please. So the challenges with this are, like I said, is access really the problem? In DC, it's not. So how does an organization like HIPS leverage our strengths to help improve retention while increasing access? The moving target. There are no easy answers, and there's a serious lack of easy replicable models. I think that we're just now, like what Nathan is doing, what HIPS is doing, the stuff that Daniel's talking about, what Boom Health is doing, like these are all things that we should be looking at to say, hey, maybe this works, maybe it doesn't. The other issue that we've been really challenged with is if you've been going to any of the large public health conferences, there's all this conversation about collaboration and mergers and You know, like we're not going to be able to have all the nonprofits and specialty populations that we have. And quite frankly, from a harm reduction standpoint, that has been very challenging to hear and a little annoying because, you know, people aren't super thrilled to have our clients hanging around their offices anyway, and there's a reason why those collaborations are very challenging and difficult. And again, like knocking on the door of the health clinics, which kind of look at you like they have no idea what you're even talking about when you try to get them to sit down and talk about collaborations. So being at the table, as has been discussed, is really, really helpful, and acknowledging that it's going to be a frustrating and challenging process, and you have to find and choose your partners carefully, and you have to push back when people just tell you that you should, you know, talk to these 3 people because they have in their mind that it would work really well. You just have to like hold your ground, but continue to look and to find partners and to take yourself out of it. And then this whole concept of prevention versus care. Most of us, as harm reduction organizations, are very comfortable working within the prevention or the social justice, you know, world. We're not as comfortable, and we don't have the language for care or for, you know, HIV care, let alone other types of medical care. And so finding a way to acknowledge and to, you know, understand the language is super helpful. Next slide, please. So where to start, and again, like I said, I think that there's going to be more national conversations about this, but go ahead, get uncomfortable. If you're comfortable, then I'm going to say that you're probably not paying enough attention, and you might want to look around at what's coming down the pike, and maybe you're going to be fine, but maybe not. That's going to cause a slight sky is falling freak out, and that's okay, get over it. Get out, talk to people, go to the meetings, go to meetings that have nothing about what are nothing about what you do, because that helps you find partners that you otherwise wouldn't know about, and get creative. And I think for me, HIPS has had our, like, you know, we've been on the ground so long, so focused on our clients that we didn't necessarily have the networks or partnerships. We were well known because we were very involved with the health department. But one of the really big things for us is the health department gave us funding to pull together a harm reduction services working group, because we had an opportunity to bring a really diverse group of people to the table to talk about what would really do to change the game for drug user health. And we had people from drug treatment, we had housing, we had we had private doctors, we had clinics. We were able to leverage the health department to pull these people together and have some real conversations. And there's some definite collaborations that HIPS has and the other syringe exchanges have access to that are hopefully coming out of that. Next slide, please. Awesome. And so I'm sorry, I know that we're running late, so I just wanted to thank everybody on this list. I was able to attend the UCLA Johnson & Johnson Healthcare Executive Program, which was a program specifically designed to helping us and helping both HIV prevention organizations and medical clinics address healthcare reform. The Washington AIDS Partnership and the DC Department of Health and the MEC AIDS Fund all gave us small pots of money to help find time to work on these specific issues and to help finish our plan. And like I said, the Institute for Public Health Innovation was the one that was pulling together the regional meetings that helped us kind of begin to think about this. And without all of those people helping us and all of those ideas at the table, I'm not quite sure, you know, that we would have as clear of a path as we do now. And so in closing, where HIPS is now is that we are expanding our community health worker model. We actually have two collaborations with medical clinics right now where we are working to improve retention rates and access, and they're just starting. We're finding really big challenges around billing, and originally we had really excited about this fee-for-service thing that we had put together, and now everybody just wants to treat it like a grant. And so that's kind of challenging, and we're trying to figure out how we can, how we address that. And we're moving forward, I think, like everyone else, and we're here, to help or do whatever we can, or just to continue the conversation with other providers. So thank you very much. Next slide.
Great. Thank you so much, Cyndee. That was really fantastic, and you have done some incredible work. So we are going to have some questions and discussion now, and everybody should be unmuted, so hope we can hear all the presenters. We have a question that came in, and this person is a patient navigator / case manager and sees a need for more outreach to access the population that's falling through the cracks. How do we do that, and how and what sources of funding through health reform might be accessed for outreach services? And this goes to any of you.
Well, this is Cyndee. HIPS has a really strong outreach component, and has for the past 20 years. I think that what we've really been challenged by is outreach is no longer really fundable under the, under most of the new rules around HIV prevention. And so we've had to redefine outreach as far as kind of medical support, early intervention, and also recapture activities. But there needs to be some way to do that. I actually think harm reduction organizations have an opportunity to partner with clinics or with other larger care organizations, because we're really good at that outreach. I think we do it better than a whole lot of other models. And we just need to leverage that to say, like, we can help you find the people that you've lost, or we can help let people know and bring people in for services, but we just need to be able to support the ability to do that.
So you mentioned, Cyndee, that you had worked out a fee-for-service model for that, and could you talk a little bit about how that worked? Is the clinic or other clinics paying you essentially on a per-case basis to bring clients in?
Originally, we had the original agreement when we were all submitting for funding, because the health department, I think quite forward-looking, sent out their Ryan White applications and said, you must engage in partnerships between care providers and other community organizations to help move the work forward. Whitman Walker Clinic also was, I think, very forward-thinking on this and started trying to develop a CBO network to help with the populations that they serve, or that they want to serve, and HIPS is one of them. And drug users and sex workers are one of them. And so we went into contracts with them in order to provide the services. Originally, we based our budget on a fee-for-service, and that fee-for-service was different whether we were bringing in a new client who was an HIV positive, or if we were recapturing someone, and that was based on our, how many hours will it take a community health worker to go find this person, how many hours will we have to build a relationship, how many hours, will we have to utilize to get transportation to and from, and follow up those kinds. That's kind of what we used to tease out what we were going to charge per client. And then so we proposed that, and then the grants came back, and we ended up kind of being on a grant basis because that's the model everybody's comfortable with. And so we're kind of like in the process of being like, well, this is why having it on a grant basis is good, and this is why having it not on a fee-for-service basis is a problem. And we are right in the middle of that right now. In fact, like, they called me yesterday, and we were talking about how we can't put in anything but staff time into the agreement, which is just really challenging for me, because I can have a staff person, but I can't have a desk for them to sit at, or they can't have a computer to do client files. And so it's challenging these old methods of funding as we move forward.
Great, thank you. That's I think that really illustrates the challenges that we are all going to be facing. Another comment that came in was that you all are getting ahead of potential changes in Ryan White funding. And I think that that is a really important point, that as health reform moves forward and is implemented, we're very likely to see reductions in Ryan White funding as more of our clients get their care from the mainstream health system. Of course, the Ryan White program is going to continue and will be reauthorized in the future, but that's certainly one of the challenges that we're facing, and I think you all are illustrating ways to work in that new environment. Daniel, we got a question for you, which is, can you talk about the criteria that has been developed in New York State for agencies that want to provide harm reduction services through Medicaid, such as the experience requirements? Can you talk a little bit about what those are?
Yeah, and so these are just kind of draft proposed, so they still need to go through different layers of approval. And I think the thinking was, so there's a tension. Do we restrict the number of entrants into this sort of new market of being sort of purveyors of Medicaid reimbursable harm reduction services, or do we cast the doors wide open? And so the experience requirements were meant to be partly a kind of quality control mechanism, so that it wasn't just somebody kind of hanging up the shingle one day and saying, hey, I'm a harm reduction provider now, but that it was focused on organizations that had a track record, because it turned out that it was actually hard to kind of quantify what makes harm reduction special and distinctive and effective as harm reduction versus anyone else saying, well, my clients use drugs, so I'm going to say I'm doing harm reduction. I think that that will ultimately be somewhat in flux, because the flip side of that is that the availability of a new funding stream means that we could potentially pull in other providers that do work with people with substance use histories who haven't traditionally done it in a harm reduction model, and say, hey, if you want to have access to these Medicaid dollars, you need to change your structure and do more harm reduction. But that was where those kind of 2 to 3 year experience requirements came from. The thinking was to create a bit of a barrier to entry to ensure that there's at least initially a high bar in terms of quality, experience, and a documented track record in providing services under a harm reduction model.
Great, thank you. Elisa or Daniel or any of you, any comments that you would like to make about each other's presentations? Or thoughts about next steps for all of you in your work to get reimbursement for services?
Well, I had a quick comment about the topic that we were talking about, that Cyndee was talking about. Here locally in Tacoma, a part of the community transformation grant seems to be, and as it was described to me sort of informally, is a help to keep people out of the healthcare structure. So I think there's this concern that the healthcare structure is going to start sucking people in. You know, it's going to be this big machine that will suck people in, and the goal is to keep people out in the community. And so that's the value that Cyndee's talking about through outreach, is keeping people out in the community and being served by members of their own community, whether it is people who speak the same language or people who are culturally sensitive to injectors, or whatever community is being served, that those people stay out of the healthcare structure. It's really an interesting thing for me to listen to them talk about this. But they're just now beginning to discuss fee-for-service and how that might work, and how clinics and healthcare providers could employ community health worker agencies. And so it'll be interesting to hear how that pans out. And I'm really glad to hear from Cyndee, and I will be glad to talk to you about this further as we start to discuss further these issues that you've already experienced. So I'm really excited and happy for that.
Yeah, and I'll just add to close. I think the one thing to reiterate is that for the most part, for harm reduction programs, nobody's specifically opening the door for us and inviting us in. We need to figure out where we fit in, and some of that's going to be trial and error. And I really encourage people to look at the behavioral health side. In my slides, there was a link to a CMS bulletin on what's called super utilizers and different programs, super utilizers, particularly of emergency room services, who are seen as a population who are driving costs and have high rates of behavioral health conditions, mental health, substance use disorders, and often dual diagnosis. I looked at that for inspiration in terms of where you might find your niche, because that has a lot to do with our populations and figuring out who's having those behavioral health conversations in your state, whether it's in terms of setting up a behavioral health organization or Medicaid health homes, or in terms of any kind of care coordination models. Those are the people that we have something to talk about with. And so behavioral health is sometimes a difficult place for harm reduction to walk into and talk to, but there's a new openness now that might not have been there 5 or 10 years ago. And I think, especially hearing about Elisa's experience, that there's new conversations that we can have.
Thank you, Daniel. That's an excellent point. I'm really struck by the extent to which all of you are leveraging the community health worker model, and there's also work going on here in Illinois to make those services reimbursable and to recognize that role in individual as a professional, and really put a value on those services and make them reimbursable, which certainly given the long history that we have in the HIV world of engaging peers in services, we certainly understand the value of that, as does the harm reduction community. So it's tremendous to see that being recognized as we move forward. All right, any wrap-up comments before we conclude from any of you? Okay, well, I want to thank Daniel, Elisa, and Cyndee for presenting today. We encourage everybody to download the presentation from hivhealthreform.org right there on the homepage. We will be posting the recording in a couple of days, and we also ask that you take a really brief survey as you sign off and provide us with all the feedback that you can. So thank you so much for joining us today, and thank you so much to our presenters. Have a great day. Bye-bye.